be in terms of focus. Now, what about coronary disease? And if you look at what we just said in terms of systolic and diastolic blood pressures in the context of coronary heart disease, you can see with age, as you go up, the systolic pressure really trumps the diastolic pressure in terms of the risk. And you can see in this slide of Stan Franklin's, it's almost linear. So, very important point to keep in mind in terms of the observation about the relationship between cardiovascular risk and blood pressure. What about family history? I mean, hypertension is a genetic disease, polygenic. We don't know what the genes are, but we definitely know that a family history clearly is important. And family history is an established risk factor for CVD events, as it is for hypertension. Half of all the cases of coronary disease can be explained by family history. 14% of families with a known family history of heart disease accounted for 72% of the cases of early heart disease before age 55. So what should be the goals of therapy? Reducing cardiovascular and renal morbidity and mortality by obtaining the goal for systolic blood pressure is really the key. Treating systolic and diastolic pressure to less than 140/90 is the general goal for everybody and really should be the focus, unless you have diabetes or kidney disease, at which point the focus should be less than 130/80 based on current guidelines. You can see the benefits in the next slide of reducing systolic blood pressure and how much benefit you're getting based on the amount of systolic blood pressure reduction you've achieved for stroke, CHD, and total mortality. So again, very important observation to keep in mind. Now, JNC 7 reclassified blood pressure. We did this because we wanted to make it easier for the physician to understand the risks and easier for the patient to understand the risks of certain levels of blood pressure. Because of the notion of aging and the ultimate development of hypertension, we use the term pre-hypertension as opposed to normal or high normal because it resonated better with focus groups we had of actual patients that had hypertension, saying that if they were told they were pre-hypertensive, they would actually ask the physician for interventions, even if the physician didn't volunteer any. We also reduced the stages to stage 1 and 2, not because stage 3 wasn't around anymore, but because we figured you wouldn't do anything differently if you had stage 3 versus stage 2. You would be aggressive and you would try to get the pressure down, and so it would be one less stage to worry about. So those are the essences, and you can see the numbers. They haven't changed at all from previous guidelines, or at least JNC 5, but they certainly were amalgamated in different ways. And again, the reason for going down to 120 was an epidemiological paper that was published around the time that we put the JNC together that showed that cardiovascular risk in ages 40 to 80 starts at a level of 115. And so, again, we wanted to make sure we captured the spirit of that in the nomenclature. Now, what do you do? Management for recommendations from JNC 7. Obviously, if you're pre-hypertensive, it's all about lifestyle. Low salt, smoking, exercise, etc. But if you have a compelling condition for a specific class of antihypertensive agents, then clearly those should be given. But if not, it should be about lifestyle. On the other hand, if you have stage 1 or stage 2 hypertension, the bottom line is that you need to be using either thiazide diuretics or a combination that involves thiazide diuretics so that effective blood pressure control can be achieved. This is really the